Afternoon, good evening from the colleagues, for the colleagues all over the world. I'm Professor Otto, Chairman of Council for Cardiovascular Surgery in Asian Heart Society, and also I'm President of Heart and Health Foundation of Turkey. This webinar has been, this session has been arranged by Council for Cardiovascular Surgery in AHS, and this will be broadcasted by both Asian Heart Society facilities as well as the unique platform of Cardio.com of Heart and Health Foundation of Turkey to European side and American side and Turkey as well. This morning session, today's session is about precision medicine in adult congenital heart disease, integrating AI, genetics, and advanced medical and surgical strategies. I will chair this session with wonderful colleagues from who are expert in adult congenital heart disease. And let me introduce them. Professor Harold Kemmerer from German Heart Center, Munich, who is a pioneer in adult congenital heart disease, and Professor Huang from Beijing and Ansen Hospital, and Professor Xin Li from Children's Hospital of Sukhof University. Now I'll hand over the microphone to Professor Harold Kemmerer to chair the session from now on. Harold, please.
Good morning, everybody. It's a pleasure for me to be on board again in this important meeting. And I think we can get started with the first speaker from the Heart Center in Germany. It's Iskert von Kodoritsch, who is a famous cardiologist and extremely experienced in patients' treatment and management with Marfan and congenital connective tissue disease. Our first presentation will focus on genetically determined aortopathies, and as you all know, these conditions can affect the aorta already at a very young age and may lead to serious complications if they are not recognized early. And today it's clear diagnosis is no longer based only on aortic size, and genetic testing and advanced imaging and so on are becoming increasingly important. I believe we will hear today how these tools can support more personalized surveillance and treatment decisions. And I'm looking forward to your presentation, Iskert. Please go ahead.
Can you share the screen?
Yeah, So can you see my slide?
Yes. Can you make full screen?
Do you see the slides?
Yes, we can see, but can you make it full screen?
All right. Thank you very much, professors. I'm very proud to be part of this session. I think that the genetic revolution really has huge accomplishments in the field of aortic disease, which is a highly lethal one, and the benefits are quite high. Genetic disease in aortic pathology of the thoracic aorta is about 20 to 30%, so it's quite a lot. Well, to look at the basic pathophysiology, it's quite simple. The aorta is nothing but a tube, and the tube obeys the logics of the law of Laplace, which means if you enlarge the diameter, the wall is thinning, and once you enlarge it more, it will be rupturing. And you can see the hinge point story. There is diameter of the aorta, which is usually at 55% diameter millimeters, when the risk of rupture is high. But you will see that the quality of the aortic wall is really important when this hinge point, or where this hinge point is located. So if you look at the aortic wall, it has 3 layers. And the most important one, and the one we are looking at, is the medial wall. And we have a lot of genes that are responsible for the metabolism and the structures of the medial wall. And once you have a defect in one of the genes that are for the smooth muscles or some of the connective tissue structures, if they are defect, then the aortic wall will be thinning and will be generating and will be capable to rupture earlier than in normal aortas. And there I show you, for example, 2 famous genes. The one is the FBN1. If there is kind of a pathogenic variant, you will be having something like Marfan syndrome, which is a systemic disease, but people die from rupture of the aorta maybe at the age of 40. And you can see ACTA2, which is a smooth muscle cell structure gene. These are people who are looking quite normal, but again, if they have a variant in that gene, they will have aortic dissection maybe at the age of 40. So these genes determine an increased risk for aneurysm and aortic dissection, and they will be killing young people if we don't have a diagnosis early enough. So what I will do is I will go through the modern idea of gene-based management of thoracic aortic disease. And you gave me 3 steps. The first is molecular diagnosis. The second is advanced imaging. And the third is personalized management. So we will start with the molecular diagnosis. And all in aortic disease in young people today is about genetic testing. So you have to make a decision, who will you be testing with thoracic aortic aneurysm or dissection? And there are guidelines. And these guidelines tell you that any patient with a thoracic aortic aneurysm or dissection that has an age below 60 years has an indication for genetic testing. If you have some syndromic features that are suggestive of a syndromic aortic disease, such as ectopia lentis or spider fingers or aneurysms at other sides of the vascular tree, and so on and so forth. Very high people, scoliosis, there are many signs. If one of these features together with an aortic aneurysm is an indication to perform genetic testing. If you ask those patients with aortic disease, do you have a family member who had aortic dissection or aneurysm as well, and you find some people in the family history, then again, you do genetic testing. So this is for the indication. And these are a lot of people that actually have an indication. And now, to establish the diagnosis of inherited aortic disease or genetic aortic disease, you can see there are rules, international rules for diagnosing Marfan syndrome, and you have certain combinations of molecular variants of aortic disease. This is dissection, but for example, family history and ectopia lentis, which is an eye manifestation. And some of the combinations allow you to establish the diagnosis of Marfan syndrome. And interestingly, you have at least 2 combinations where you need molecular testing. This is quite conservative. But if you look at more recent rules for diagnosing thoracic aortic disease syndromes like Lustitz syndrome, you can see that you always require genetic testing to establish the diagnosis of Marfan syndrome. And all experts would say that any diagnosis of genetic aortic disease today requires genetic testing. So genetic testing is quite essential and central for establishing the diagnosis of genetic aortic disease today. So the next step, advanced imaging. So we need modern tomographic imaging modalities for establishing the risk, for estimating how people are really affected and what the prognosis with respect to mortality is really about. So you need a phenotypic characterization. And here, the modern imaging modalities are a key investigation to establish the risk and to establish the phenotype of these patients. And you can see that from head to toe, you can scan people with a CT or even better MRI. And there are a couple of issues that I will not dive into very much, but you can see that the configuration of the skull, the configuration of the skeleton, of the thorax, of the hips, of organ cysts, and a lot of things are associated with genetic aortic disease, some more or less subtle signs, some are very huge, but you can all see this with tomographic imaging. So it's quite central to assess the systemic risk of these patients. Secondly, you need imaging modalities for standardized measurements of the aorta, not only the aorta, but also the aorta. And you know that there are guidelines how to measure, because there is a huge variance of aortic diameter assessment depending on how you measure. And if you don't apply established methods, you will be ending up with some fake kind of measurements, and you will be ending up with false surgical decisions. And that's why you have to approach these measurements in a standardized way. I've shown you the aortic root, which is the most central structure of the entire aorta that is affected by genetic aortic disease, and I have shown you how to measure with a CT scan in a regular way the maximum diameter, which is in the cusp convention or cusp to commissure convention. And you have the same thing for other systemic manifestations. And I showed you as an example to assess vertebral scalloping as a sign of dural ectasia, which is a sign of genetic aortic syndrome as well. So you have to do standardized measurements and follow some guidelines in that respect. Finally, if you have measurements of the aortic root, you have to normalize these measurements to body size, age, sex, and so on. You can use platforms and nomograms, which I show you, for example, in this slide, but it's very important because if you have a 2-meter large man with a 40 millimeter diameter of the aortic root, it is not clear whether this is a dilatation or whether this is normal in that body size. So you have to calculate z-scores, which is for the Gaussian distribution. Where is he really with his size? Is he above 95% of size in the normal population, or is he not? Very important. So, and you can calculate the z-scores here, as I have shown for an example. Finally, personalized management. This is a key issue as well. And I show you that if you have diagnosed someone with, let's say, 40 millimeter aortic root, and you find fibrillin 1 gene pathogenic variant, then you can see in guidelines here, the ESC guideline of 2024, how is the follow-up imaging protocol to be performed. It depends on what gene you have and what diameter you find. I don't go into details, but it's very important that the follow-up imaging structure and protocols depend on the gene and on the size of the aorta that you find. And only if you have these at least two determinants, you can really structure a guideline-based program for structured follow-up of these patients to prevent aortic dissection and not to experience any kind of surprises in these patients. Secondly, you have a gene-based surgical decision-making, which is a very central thing. And I summed up the most important recommendations for elective surgery with replacement of the aortic root, depending on the gene that carries the variant. I don't go into this, but you can see at one glance that there are gene-based differences in the timing of surgery, which is essential. If you don't do this, you may experience people that are in your follow-up programs that die or have to be operated upon for type A aortic dissection. And as you know, these people have a bad prognosis. They may not even make it to the surgical suite, or they may end up with post-traumatic trauma, and so on and so forth. You have to follow these guidelines, and to do that, you need genetic testing again. And even more, it's not just about timing of surgery, but it's also about how to operate on these patients. And I show you here an example where we put a TEVR into a patient where we did not know that he had a Marfan syndrome. And the result, if you look at the left panel, looks really fine in the initial placement of the TEVR. But if you look at it 2 years later, you can see that the aortic arch is displaced along with the entire prosthesis. And this was short before rupture and dissection or anything. So we had to take him to surgery and replace the whole aortic arch in that patient. So very important. The surgical techniques of repair depend on whether there is a genetic disease or whether there is not, even the choice of the techniques. So if I may sum up my talk, first, genetic testing. You have to perform it in all patients with an age below 60 years or a family history of aortic disease or some syndromic features. Second, if you perform advanced imaging, it is to assess syndromic features. It has to be performed in a standardized way. Measurements have to be normalized. Third, personalized management should be gene-based, structured follow-up protocols. There should be surgical indications based on the gene that is affected, and techniques have to be tailored to the gene that is affected. So that's it. I thank you for your attention. I'm done. Professor Otto.
Thank you very much. Again, the great presentation. And I think there are so many questions open. And if you all agree, I would recommend that we have a few questions after your talk just now. Is it okay, OZTEKİN? You agree?
Yeah, okay. We can do that.
If I may get started, Iskert, perhaps you can comment on genetic findings if there is a result of unclear significance. How do you handle this situation?
Yeah, again, there are guidelines. So if you have a VUS, variant of unknown significance, guidelines say you should not base any of your medical decisions on the presence of that VUS. It is as though it is not existing. But what you have to do, of course, you have to keep it in mind, and you have to reevaluate the meaning of that variant after 4 years, because usually there may be new data on that variant in huge databases and so on, and you may see that variant in a different light 4 years down the road. So that's the way you have to handle it based on guidelines. And what I am doing is I tell patients, don't worry about it, but I handle them as though they have some kind of variant, especially if there's already some aortic disease, which should be there. And so I do follow up similar to the protocols that are suggested for that gene with a pathogenic or likely pathogenic variant.
Thank you. If I
And
may,
also,
sorry.
I also wondered if I may, you are more careful in Loeys-Dietz syndrome more than Marfan syndrome. You recommended to wait until 5 centimeters in Marfan, but mostly you are recommending surgery around 4 to 4.5 or even 4 centimeters in Loeys-Dietz syndrome. So
yes,
is it just numbers, or are you really recommending this?
well, it's not me, it's the American society, and it's the European society. Actually, they suggest the same diameters as thresholds for surgery. I'm a bit skeptical because the data basis is very small. And of course, you have a lot of variance. But what the guidelines do, and which is quite reasonable, for example, if you have in a Marfan syndrome some additional risk factors, like you have dissections in the family of that patient at a very early age or at very small diameters, you would say this is a risk constellation, and you would perform a surgery in a Marfan also at 45 millimeters. So it depends a little bit, and you can see the same kind of approach is also pursued in Loeys-Dietz patients. You have those without risk factors and those with risk factors, and so it depends a little bit. And I think the guidelines are for those who are not experts. And I think that we, of course, look at a lot of things like the shape of the aortic root, how does it really look like, and so on and so forth. There are really a lot of factors. And we really do an individualized, or as we say, personalized decision. And what is very important, very, very, very important, is that you really do shared decision making, because we are handling risks and we are weighing risks, the risk of surgery against the risk of dissection. And if you work really with excellent heart surgeons, where the risk for surgery is very low, and there is some doubt about the pathology, I think the way sways to earlier surgery. And so I think we are more aggressive than others. But it has to be personalized, and the decision of and the preferences of patients at that place are really very, very important. And it's amazing to see that the risk attitude of patients is very different. Some simply want to get rid of the topic and the problem, and they say, well, just take me to surgery, I don't mind. And others would like to evade the necessity of surgery as long as they can. So it's really different, and you have to tailor it a little bit also to the patient.
I think
another question, Iskert, you mentioned the Z-scores and the assessment of Z-scores.
Yeah.
My personal impression, is that if you go to the page or from Marfan Foundation and compare it, for instance, with the page of Yale for aortic diameters, there are big differences sometimes. Do you have the same impression or not?
No, it's not an impression. There are various normograms, and these websites do not tell you with how the measurements have been performed, because usually they think it's echocardiography that is used for these measurements, and there is a huge variability of how they measure. Some do it in diastole, some do it in systole, some do it inner edge to inner edge, some do it leading edge to leading edge. There is all kinds of and the nomograms that are available are tailored for certain age groups. They are tailored to certain ways of measurements, and you have to be very concerned, and you have to know what kind of method they have been using. And so, of course, the nomograms produce different suggestions. The one that I have shown you is from Paris, and they are using a couple of normalized values. And I always see that the z-scores are not the same. And so you are right with this. It's not at a perfect point yet. And it's amazingly different to find a consensus about something so trivial as how to measure the aortic root with echocardiography. I think it's ridiculous, but that's where we stand. Okay. And so you have to be very careful.
Okay, thank you. And I see we have just time for one further question. Perhaps I can also ask this question. What you didn't mention is prophylactic medication.
Yes.
And is there any chance to get some information from genetic basis to judge which medication they should have? Beta blockers or AT blockers, or what do you think?
Yes, there are differences. They are not very huge, but one should be kept in mind that I didn't talk about vascular Ehlers-Danlos, which is a very rare and very toxic kind of variant. And it's as it is rare, there are only a few studies on medical treatment. And the only studies that are available have been performed with a certain beta blocker carvedilol, and so celiprolol. I'm sorry, and celiprolol is a specific beta blocker, and if you don't want to do something wrong, you should use this one in vascular Ehlers-Danlos. And for the others, I think we can say you can use a beta blocker, a cardioselective beta blocker, and you can use a Satan, and you can use the combination of these two. And well, you could go into details. I think the most famous randomized blinded study has been done by LACRO, the American study, and they have done it with atenolol and in the combination and versus beta blocker and as atenolol and losartan. And so you can use this if you are very picky about evidence-based medicine, but there have been other studies with other beta blockers and also with other Satans. And so you should use these two substance groups in all patients except for those with vascular Ehlers-Danlos, as I have explained.
Okay, thank you very much again, Iskat. And I think we have to change the topic. And the next presentation will be given about sudden cardiac death and adult congenital heart disease by Junyan. And all people know that cardiac sudden death is one of the most serious concerns in adult congenitals. And at the same time, it is often difficult to predict who is really at risk. And I'm sure that the following lecture will help us understand how to identify high-risk patients more accurately, and perhaps how precision medicine and AI may support us in the future. Please go ahead.
Yes. Thank you very much. Good morning in Europe and good afternoon in Beijing. I'm Dr. Yan from Anzhen Hospital. It's an honor for me to give the talk about sudden cardiac death in adult congenital heart disease, precision medicine, and AI-driven risk stratification. The content will be consist of the 6th section. the first section will be the background and the epidemiology. How to understanding the scope of the adult congenital and the burden of sudden cardiac death. The key point factor is that the global congenital heart is about 10 million adults. Maybe that's greater than 90% of congenital heart infants survive to adult. In China, about 110 new cases per year, a total about 3 million. So maybe the fastest growing population in cardiology. Maybe the unique challenge is life burden, congenital defect with a surgical scar and acquired disease, unique erythemogenic substrate, and some the care gap, some lack of the pediatric to adult transition fragment in many regions, and some late complication in the heterogeneity, androgen anatomic variant, and we have the individual surgical history. You can see the sudden cardiac death, about 25% of the adult congenital mortality. The general population about 15%. So the median death age in adult congenital heart disease patients is very young, 30 to 40 years. From the simple, such as simple congenital heart disease, such as ASD, VSD, that 0.1% to the complex congenital heart disease, that will be 0.2 to 0.5%. So the unexplained simple arrhythmic sudden cardiac death is predominant. It will be 25%. You can see with some of the abnormality with simple ASD, VSD, after repair, the low risk annual risk is less than 0.5%. And the tetralogy of fellow repair is moderate risk. Coarctation also the moderate. In the PGA, this is the atrial switch, not the arterial switch, is high risk. And for the fountain, after fountain circulation, there's be high risk, and such as more complex congenital heart disease, such as appetite anomaly, is high. So the clinical insight is some the risk varies tenfold across the region. The pathophysiology of the sudden cardiac death in adult congenital heart disease, maybe some of the reason is re-entrant ventricular tachycardia and the cardiomyopathy progression. You may see the ventricular remodeling and fibrosis, and some hemodynamic factor such as volume pressure overload and progressive valvular regurgitation and others. So the unique feature of the adult congenital erythemogenic substrate is the something like this. Sorry. Oh.
Hello?
I can't hear anything.
Yeah,
Oh, sorry, excuse me, Professor. Maybe there's some network
Hello?
connection problem with Professor Yan. Just please wait for a while.
I think there is a connection problem. If
Yeah.
it will, okay.
Okay.
Is it coming?
Uh, 不好意思，严教授，您这边可以重新共享一下吗？
Something wrong?
We have now some AI-driven risks, I think.
Sorry about. Yeah. So the
Can you go full screen, please?
full.
The other one. The other one. No, not that one. Yeah, that one.
What? Something wrong with it? You can see the traditional risk stratification.
Yeah, okay. Perhaps you can continue like this, not full screen, if you cannot do full
Yeah.
screen.
So the second part is traditional risk stratification. You see the clinical risk factor. Traditional, we use the symptom and the functional status and the recent history and the exercise capacity and the surgical factor. That's the traditional factors. The key evidence is such as this is sorry. So the second is the ECG graphic marker with some QRS duration, especially the fragment QRS, the 2 notch in the limb list, that is superior to the some QRS duration. So the clinical insight is surgical error the method. That means we use the greater than 150 milliseconds. That will be proper. And the cardiac MRI fibrosis and scar imaging is now the late gadolinium enhancement. That will be important thing, especially from the literature that is used in fountain operation to the fountain risk. So the risk screening system prevention adult congenital heart score from the literature is from 2021. Use the score that is some of the different the Spanish and some of the other score that's TGA actually. So that use a different risk system. The three part is AI-driven risk stratification, leveraging artificial intelligence for precision prediction. We use the technology consists two parts. That means traditional machine learning something, and deep learning, that CNN imaging and are transforming. And usually, then adult congenital unique advantages. The handle the heterogeneity across the hundreds of variants and discover nonlinear association invisible to statistics and integrate large-scale multi-center database. So we use AI adult congenital risk prediction pipeline. Is that this data collection, processing, and the AI model, and the risk score, and the clinical decision. So all the area, the normal biomarker, that's the AI ECG use maker. That means the delta and the age, that will be the better one. So the clinical implication is ECG age reflects cumulative cardiac damage beyond the coronary age. So the severe congenital heart is the greatest delta age is 15. So the heart biologic older than the patient. So we also use the multimodal model. We can see the architecture here. Then the 3D VT, and also use the EUR data and the image of the GRA. So the multi-fusion modular will be equal to the sudden risk prediction. So the explicable analysis. In the deep learning with the CMR imaging, this is from the Japan National Research Study. You can see the processing, So that will be give some CMR radiomics in adult congenital heart disease, some emerging evidence, new evidence. You can see that thing. Then some other for the federal learning in adult congenital and AIP risk stratification. So this is some of the things where you must to understand and to study the challenges in actually for cardiology. you should know something about this, the challenge and the description and that potential solution. So that will be the explainable and the interpretability to explain this the method and the principle and the application, but there's some limitation here. So the regulatory perspective on this one, that's so AI model performance summary and the AI. So there's some model use the DCG and the other. So the key takes away from the AI evidence is all model consider outperform the traditional risk indicates left ventricle, and the multi-perfusion will be achieve good accuracy. External validation is necessary. ECG-based AI offer the most scalable and cost-effective screen approach for broad adult congenital heart disease population. The fourth section is precision medicine approach from the population-based risk to the individual care. So you can see that from the genetic testing in adult congenital heart sudden cardiac death for the genetic basis, there's something useful, especially in tetralogy fellow. In tetralogy fellow, you can see some of the family history will be the cardiac screen. So the tetralogy fellow with the absent primary valve artery anomaly, that will be genetic will find something. So will be the genetic testing framework, phenotype, genome panel, and variant interpretation and the case type. That means that. Another genotype and phenotype, genotype and genotype, phenotype for the correlation, the precision therapy will be give the mutation at phenotype. This is very something useful. So the application used here and genetic tool and to the clinical impact and with status here. So the will be variable division and remote monitoring. This is the current gap and the future needs. And the fifth section is a clinical application and guideline, translating evidence into practice, how to practice it. The risk stratification outcome, a high risk, you can see the ICT implantation and the transvenous perhaps, and to the moderate will be HBS or ICD if you need it. But for the low risk, regular follow-up with rhythm monitoring and periodic you do the CMR and the heart. So it's special considered for the dive selection. You can see there's something the selector you can equipment. There's a special considered for the subcutaneous ICD. That is also available. You can see the feature and the transverse ICD and the subcutaneous and now there's a variable SD. In China, the sudden cardiac death about the rate is that 10 in 2021. The patient will be 3 million, 3 million, and sudden cardiac death greater than 50%. ICD implantable rate is very low. So the future direction for China is national adult congenital heart disease registry, and AI assisted screen. And the third is capacity building, the specialized center, and some training multidisciplinary team, encourage ICD and VCD availability. So the future direction and the conclusion, challenging opportunity and path forward. The technical challenge and the clinical barrier. So the solution and pathway, the collaborative network and the regulatory harmonization and the clinician education and the patient engagement. So the main point is sudden cardiac death is a leading cause of the death in adult congenital heart disease. Annual risk is 0.1 and 0.5%. And the current prediction tools have low positive predictive value. AI, ECG, deep learning accuracy predicts 5 years mortality in adult congenital, outperforming the traditional markers. And multiple AI fusion, imaging, clinical, and ECG is a key direction for improving prediction accuracy up to 0.89. So the precision medicine integrated genetic testing, variable monitoring, and the digital twin for the individual, the therapy. So the last one, from one size fits all to one patient, one strategy, and the AI-based precision risk stratification is performing adult congenital sudden cardiac death prevention. Thank you very much, and the chairman and the colleague.
Well, Dr. Yan, thank you very much for giving us such an overview and showing how complicated these decisions may be for the assessment of the patients. Perhaps you can summarize in a few sentences for someone who is not experienced in treating such complex patients. What do you think are the most important clinical factors for predicting cardiac sudden death? What should the physician, the primary care physician, think about?
Thank you. You see, I'm the pediatric and congenital heart. I'm the cardiac surgeon. But we from our cardiac surgeon perspective, in surgery, we must do some the work to less damage to the incision in the heart. That means we have the suture less. That means there will be the scar will be small. That will be the after operation, the ECG or some of the physiology, that means will be less. So that means we must do especially in the complex case of the congenital heart disease, you must do the surgery. Well, then the prognosis after that will be good.
Okay, Doctor, thank you very much for your presentation. And I think we have to switch now from the more internistical or medical problems to the surgical problems. And the next speaker is Professor Dewald. He is head of cardiac surgery in Karlsruhe University of Greifswald. And he is experienced also in adult and pediatric congenital heart surgery. And it's my special pleasure to get some information from his side regarding the ROS procedure in patients in the adult group. Thank you.
Oliver, just before your talk, I would like to remind to the colleagues who are reaching from eCardio.com, the Heart and Health Foundation platform, can ask questions by pushing the button at the bottom of the screen, and the questions can come to me, and then I can direct it to the presenters. Yeah, Oliver, now you can go on, please.
Sorry, it's somehow everything got frozen and it's restarted. Well, first of all, thank you very much for a very kind invitation to this great meeting, and it's a pleasure and honor for me to give this talk and thereby contribute to the success of this international meeting. Well, the ROS procedure in adults is really a kind of renaissance. It's not on the broad basis yet, but I have the impression it's picking up still pitfalls with it, and it is well, it's a kind of a tricky title. Is it a Trojan horse? And I would like to show insights into it, whether this could be dismissed or is it still for some people. So without conflicts of interest, let me. And those days, and I started my training at the end of the 90s, the world was just fine, you know. We had valve replacements, we used mechanical prosthesis, biological prosthesis, clear-cut age limit. You can use homograph those days if it was available to your center. But even those days, there was an old leak described in 1967 that you can use pulmonary graft in the aortic position and then use a homograph for pulmonary. So Donald Ross described this very early during the development of cardiac surgery, and practically his original work included 151 patients with 2 different techniques, starting at the beginning, but this is what I find interesting. For the most patients, he used so-called inclusion technique, where you leave the root as it is, and he used the root replacement technique only in 20 patients, where you practically replace the whole root with a new autograft and then reimplant the coronary arteries, as you can see in this drawings. So the inclusion technique he used these days is geometrically demanding, because if you imagine you have the root and it's still fine, you down the autograft into the position below the coronaries, as you can see over here. And this has to be geometrically perfect in order to practically retain the functionality of the new valve. And then if you have a root dilation, then it becomes even more demanding, because then you have to leave the wall of the pulmonary autograft there and practically just attach the coronary arteries to it. But still, this may pose some tension to the whole system. So root replacement is obviously easier to implement and to reproduce than the inclusion technique. And this was a fairly clear thing already at the beginning. So what are the indications for the ROS procedure? Let's go a little bit back to the basics. So we're talking about young patients. We are talking about the aortic stenosis the most, and the regurgitation only when repair with the native valve tissue is not feasible. So there are some patients there where you would use that, and you have many which have already been operating on as a child with a congenital heart disease, and you also have women considering pregnancy. There's a variability of these patients when to use this. At the same time, you have to be very careful about picking up the right patient, because if you have more than a mild regurgitation on the pulmonary valve, you cannot use the autograft. The next thing are the aortopathies and connective tissue disorder, where Professor Controversies really went very well into the I would just say, well, you could use ROS in patients with bicuspid aortic valve and some aortic dilatation, which is obviously not a genetic modification of the aorta. Then chronic immune diseases is an option. Then arterial hypertension is a coronary artery disease, and poor ventricular function are the issues where the ROS procedure may not be the best. And life is less than 15 years, actually in chronic kidney disease or radiation therapy circumstances, then ROS procedure may not be the best bet, even though the patient may be young. Carditis is becoming more and more a relative contraindication, because small series published out there are showing that this could be a viable option, but this is again in very experienced hands. So in the light of the session we have right now, I would also like to pledge for the individualized concept for valve surgeries in general, but especially for the ROS procedure. So you need to make a correct indication, and you have to base that on numerous factors, and some of them are only simply mandatory. So in my eyes, it's mandatory to have echo and CT, and the whole body CT, in order to figure out the anatomy, to figure out where to put the cannulation, to figure out what is your plan B if you have some problems, and so on, and maybe also to find something which is somehow clinically inapparent and may become an important thing post-operatively. And special situations are extremely important in this matter, and these are the redo surgeries and the coronary anatomy, which is also one of the very important things when you plan where to put and how to put your autograft into the right position. Aortic disease being obviously one very important factor, as I already mentioned. So pitfalls in planning may lead to the autograft failure, so you have to be aware of those. Endocarditis, annular dilation, the aortic dilatation as well, and especially the diameter mismatch between the both aortic and pulmonary valve annulus. So if you have more than 10% mismatch, don't do it. There are better things to choose, because the available therapeutic options are nowadays really broad. So if you take ROS procedure as one of the options, you always have a homograft by itself to put in there as an option, but this may pose a risk that the homograft may calcify over time, and you get another problem during the years. You can use the Ozaki procedure, rebuild the valve using autologous pericardium or even bovine pericardium, but still you can use also a biological valve. You can use a TAVI, especially in the US. You see that they're implementing TAVIs in young patients. And you can also use a mechanical valve, which is kind of old-fashioned, but it still works well and it may even have a less risk on the long run in some comparative studies out there. Regarding the TAVI implantation in patients less than 50 years, I'm very critical about it, but I think this is not the topic of this talk, but one should really carefully choose the patient for this type of therapy. So back to the individualized concept for valve surgeries, the comorbidities are very important. The biological age is very important in my eyes. The occupation is something you need to talk to your patient with. And it's his own physical activity, sports, and everyday life at the end of the day. So the personal lifestyle and also his psychosocial environment. So how embedded in life is he at all? And then you also have to consider the reinterventions on the long run. So if we're talking about the re-replacement at some time point in the life, that may be a very, very important issue, because just think of the young patients which got the surgery already as a child, and they already have a root replacement as a child. So these are all things you need to consider in this individualized concept, but also just the basic things as strict long-term anticoagulation, if this is not an option for the patient, so there is no option for mechanical valves. So you see there is a large variability of factors one has to take into account in order to find the right choice for the right patient. So the evolution of the ROS procedure is being accompanied by the mere fact that the annulus and bulbous dilatation may occur with this pulmonic valve tissue and pulmonary artery tissue, and therefore there are certain strategies how to reinforce the neo-root and how to practically avoid the bulbous dilatation over long term. So if you look at the results, and this is Toronto, which reported more than 20 years follow-up, having more than 200 patients at a fairly young age. Their cohort comprised of more than 80% of congenital heart disease patients, and 50% of them got the inclusion technique. So the demanding patients and also the demanding technique, they have an excellent survival rate. After 20 years, they show 89%. They show redo in 30 patients due to autograft, around 40%, and redo in 3 patients due to coronary artery disease. And this may be even more over time, the older the patient can get. And if we look at the probability of ROS-related reoperation and reintervention, these are fair numbers. I mean, after 25 years, approximately 25 to 30% of the patient need some reoperation. I think that is just fine. They found no impact on surgical technique on autograft failure. So if you look at the probability of moderate and severe AI, this is practically fairly low, even though the numbers become very low after 20 years, as well as the pulmonary or homograft dysfunction, which tends towards 1/5 of the patient, or even one quarter of the patients. So another study from Stuttgart, also a long-term follow-up, almost 800 patients, which is very, very remarkable, and a little bit older than the Toronto group, the same amount of congenital heart disease. And they used from the beginning the root replacement technique, so there is no inclusion, and maybe this is also part of their success story. So if you look the survival rate, this is fairly impressive. It's more or less the same as in Toronto, and the numbers are getting low after 20 years, and at the same time the results are really good. They reported also 14% reduce, and they described that this is in regard to autograft in 56 patients and homograft in 33 patients. And they also described that they had a failure in both autograft and homograft in 23 patients. So the numbers are similar, but after 20 years, you end up having a redo approximately around 2/3 of all the patient, and that goes sharply down. So it may be that this is where the story can become a Trojan horse for the surgery. So this is a hint where we need even longer term data in order to define what is really good and what is not. Still, their autograft repair rate is about 50%, and this is very impressive because it shows that, well, if it fails, you can still work on it. And along the largest study out there is the German ROS registry with 20 years follow-up in almost 2,500 patients, mid 40 ages. Unfortunately, they did not report the congenital heart disease status, but I assume that this should be fairly large. They have a mixture of inclusion and root technique and both, so root replacement and reinforcement in almost half of their patients. And they have survival rate a little bit less, 25 years only 76%. And practically they were able to show that the ROS survival over those 25 years is more or less comparable to the general population survival. And this is a very interesting fact, so which would practically be a solid basis to give a boost to this type of surgery in future. So if you're comparable to general population, hey, what better could it be? This registry showed that the reintervention rate is also around, well, growing after 20 years of time, and you have freedom from reintervention of approximately 70% after 25 years. And at the same time, the freedom from right-sided reintervention is even better. So after 20 years, more than 80% of the patients still have their original homograft in there. The risk factors, and this is a very elaborate study, and it shows very well that most things like root replacement reinforcement decreases the risk, and you have a pure AI, which is a risk factor. But very important fact is that if you use a biological valve for pulmonary position, then you will end up with a very high risk of redo. And this is very important fact. So the biological valves practically do not perform well in this position. Many of these data and many other studies, which are not so large, contributed to the expert consensus paper for ACTS for adult patient. I would not like to go into the details because it covers really very well all different aspects. And it gives you a solid pathway how to choose for the right patient for the ROS procedure. So look it up if you're into it. And at the same time, they provided practically free, better said, 4 key messages based on only one RCT out there, so randomized controlled trial, and very few registry data, German ROS registry being one of the most important ones. A long-term solution for pulmonary replacement is still an issue, despite of the important benefits for the patient below the age of 60, they say, and they kind of reinforce the use of ROS procedure. So if you look at the other guidelines, European Society of Cardiology and Thoracic Cardiovascular Surgery, well, they just mention it out there in one diagram without recommendation, which is kind of a pity. Well, but there are not so many data about it. The American guidelines have only a weak recommendation for ROS procedure below age of 50. So it's a 2B recommendation. And so it just shows that there are really many things to fix in order to implement this type of surgery to the broader population. So pulmonary conduit issue is still a strong problem because you have poor availability of homografts in many places, and you have a lot of times the ROS centers trying to build up the program, or very few well established, but still the patient service is under limited resources, and this is not only the availability of surgeons who are able to perform this procedure. So then there's another discussion out there, who should do it, pediatric or adult cardiac surgeon? So that's the point. Structural long-term surveillance, who can do it, who is able to do it, who has the knowledge and who has the capacity. We need to pull the patient into registries, and we also need to have more studies, more good studies, in order to develop the guideline recommendations. In summary, I would like to come to a conclusion that we are talking here about a good but technically complex surgical option. But these patients, they need to have almost no comorbidities. And so these patients are very rare. Still, the long-term results are good. They reflect the good refinements in technique. But it remains as a demanding and challenging procedure to implement it. So yes, it's still a Trojan horse for new centers especially, and for the established one it may not so be anymore. But I think there is a solution for this problem. So at this point, I would like to stop and conclude my talk, and thank you very much for your attention.
Thank you very much.
Professor Dewald, thank you very much. A great presentation again, and I think there will be many questions from the surgical colleagues, but perhaps I can get started the discussion with a question as a cardiologist. What do you think, what kind of long-term follow-up is needed after a ROS procedure? Have you any comments on it?
It's not just about time, it's also about the quality. The results I just show, they show up to 20 years it works well, but what is going on after that? We don't know that yet. We need to figure it out. And as we see it now with evolving TAVI data towards 10 years, there is really a long-term perspective we need to take care of, because these are patients which have 20, 30, 40 years of life expectancy in front of them. So we need to have solutions for them. And in terms of follow-up, then this is the utmost important feature. You have to be stringent in the follow-up. You have to keep an eye on these patients. And the moment it starts to deteriorate, you need to pick them up and find the right solution to either repair it, or give them another option. And I showed numerous ones. So I don't think there is any option out there which cannot or should not be performed. It's, again, very individual decision at this point.
Dr. Zinli, do you have any question?
Yeah, thank you, Dr. Otto. And I'd like to ask a question that, in your opinion, what is the best solution for the right side conduit for the ROS procedure? Because in China, in the recent years, we are using a handmade valve inside the AORTIC conduit to perform on the right side for ROS procedure. So what's your comment on that?
I think this is a very good option, because you have a solid structure where you could do the intervention as a intermediate step. The data show very well that the biological solutions may fail at this point, and maybe homographs would hold the most, but the availability is poor, to say it mildly. So in my humble opinion, even putting a biological valve is a good option in there, even though it may fail after maybe 10 years already. But you have a solid structure, you have a strut where you can place the TAVI. Use Melody, any of the implants out there would fit. And thereby you could at least, I guess, go over 20 years. And what's going to happen then? Well, the larger valve you put in there, that may even give you opportunity to put practically TAVI in biological valve prosthesis, so you can also go maybe beyond 20 years. So I think your approach, having a solid Dacron conduit which can hold any kind of a implant, is a good one. And then, well, I like to use autologous pericardium for Ozaki, for example. I guess building up a valve out of the patient's own tissue is probably a good solution. So yeah, I would say go for it. And it was very interesting to see how the data are, but we have to be very patient to get the solid numbers out of that.
Yeah. Thank you for the comment. Yeah, we'll see the long-term data. Yeah.
Do you recommend a reinforcement for the all new surgery nowadays, as it hasn't been done in the past, but we have good science or good papers supporting reinforcement of aortic annulus at each operation? What's your comment on that?
I would do so in all adult patients, obviously in children, and maybe you could start with teenage at 16 or 18 years of age. Anything beneath that doesn't work because it has to grow. But in others, I would go for it. Yes, I would recommend it because the redos are doable, but how many redos can you perform during the lifetime? And this is then again we are talking then about the individualized concept. So if you start at the age of 20, I would then reinforce it even more because there is a long perspective behind that. If you do Ross in the 50-year-old person, well, you may even skip it, but still it may encounter you at the age of 60 or 65. So the earlier you start and the more complex your start is, the better is to practically use everything which is out there in order to stabilize it, to reinforce it, and hopefully to keep it for a long time period as it is.
If I may, I'll introduce you a case and ask your opinion about that I received just yesterday from Germany. He was operated in a familiar center in Germany in neonate period, and she's now 10 years old, totally asymptomatic, but the first operation was the aortic coarctation operation during the neonate period, but as it is common now due to the bicuspid aorta, she had a very severe aortic stenosis, valvular stenosis, with the 80 millimeter mercury of gradient, and on top of that, a recoarctation with 33 millimeter of mercury. So what would you recommend, or how would you go with surgery with this young girl, young lady? Ross procedure or this mechanical valve? And there was just a little bit left ventricular enlargement, but no dysfunction yet. So what's your suggestion?
May I just, a short question, may I just ask, is there a LVOT narrowing?
No.
That's normal.
No.
Well, I guess you can go for Ross. You can even think of Ozaki as an interim step and somehow get the kid towards the age of 16. If you don't use a Ross now, use maybe Ozaki and then go for Ross at the almost young adult age where she's already grown up, so you have a final diameter, and then use the Ross. Mechanical valve in terms of pregnancy and family build-up and so on is a troublesome issue. And I think the root replacement at this age with Ross may become an issue over a long period of time. So maybe Ozaki and then later on Ross may be a good step. But there was no surgery on the aortic valve yet, was it?
No. But VST.
So you have a native.
Yeah, but VSC closure at the same time.
Oh,
during the
okay. Well,
partition.
but the root, the aortic root is intact. That's the most
Yes.
important thing.
Yes.
So because I have an impression then, I don't know how many root replacement during the lifetime can one patient practically survive. So if you're talking about the second root replacement, you're in really high risk bracket. And if you're talking about the further root replacement, I think that can become really troublesome for the patient.
How about
So
recoartation?
somehow for the
How about standard?
coarctation, I think it would be good to get rid of that fairly shortly after you fix the aortic valve. If you try to do that before, is not bad, but that your anesthesiologist may become nervous on that because you need to expand the balloon and so on, so this may be a trouble for the left ventricle. You could do a hybrid procedure as well if you have the capacity of hybrid room and do both at the same time. That would be very nice because then you relieve the afterload as well at the same time.
So the patient is living in Munich, so they prefer to go back to Munich Heart Center again.
I think it's a good place to go.
Yeah. As he was operated for the first time, and I gave to them, to the family, Harold's name to get in touch, perhaps.
Yeah.
So, Dr. Zin Lee, perhaps you can introduce the final lecture.
Yeah. Okay, thank you, Dr. Otto. Since we have running out of time, I would like to quickly introduce our last speaker for this session, and Dr. Chen Zhou. He is from the Union Hospital, Tongji Medical College, Huazhong University of Science and Technology, China, which is the largest heart transplant center in China. So welcome, Dr. Zhou. Is Dr. Zhou online?
Yeah.
Okay, I would like to share my PPT.
Oh, yeah, please share your slide.
Okay.
In the meantime, I can remind again that the Turkish or European colleagues who are connected to via a cardiocom can put questions by clicking the button at the baseline. I can see the question and then direct to the lecturers.
Okay.
So you can see.
Yes, we can.
It's
see.
okay.
Yes.
Okay.
Yeah, Dr. Zhou, please.
Okay. Thank you for the introduction. It's a great honor for me to introduce our experience of heart transplantation for adult congenital heart disease. I come from Union Hospital in Wuhan, Hubei province in China. My name is Chen Zhou. We all know the congenital heart disease is the leading cause of birth defects worldwide. In China, it's also affecting about 2.2 million people. And as to the heart failure, it's also a very huge challenge for the world. But we all know the medical therapy for end-stage heart failure has very poor outcomes. Even with the standard medical therapy, the mortality rate is over 20%. So we believe the surgical treatment, especially the heart transplantation, is a very important treatment for end-stage heart failure. The proportion of the end-stage CHD varies with the age in heart failure patients. The younger the age, the higher the proportion of end-stage CHD among heart failure patients. As to the heart transplantation, the CHD accounts for overall heart transplantation approximately 12%. This data is from international data. And then for the adult patients, the proportion of CHD accounts for only 2%. But in pediatric patients, especially for infants under 1 year old, the CHD reaches more than 50%. There are many characteristics of heart transplantation for CHD patients. In these patients also associated with pulmonary vascular malformations and other anomalies. And this patient often associated with elevated PVR or hypoplastic pulmonary artery. And most of these patients experienced a previous surgery. So nowadays, the congenital heart disease is still a major risk factor for 1 year mortality after heart transplantation. One interesting thing is for adult CHD heart transplantation, the early post-transplant survival rates in this group are lower than those without CHD disease. But the long-term survival is better for these patients. In China, from 2015 to 2019, the CHD accounts for 2.5 to 4.3% of all the heart transplantations. So in pediatric populations, the CHD accounts for about 30% of the patients, and in adult population, the CHD accounts for only 3.4%. The indications of heart transplantation in end-stage CHD are adapted from general heart failure guidelines because there is a lack of specific CHD-focused transplantation guidelines. The key indications are similar, including the refractory heart failure, untreatable complex anomaly, or malignant ventricular arrhythmias, and extremely decreased exercise tolerance. The main contraindications including the irreversible elevation of PVR, the multi-organ systemic failure, and uncontrollable systemic infection, etc. The single ventricular patients represents a unique subset in heart transplantation of CHD. The heart transplantation is known as stage 4 of the Fontan series of operations. And the transplant may be indicated at any stage during the disease course. The transplantation mortality rate after Fontan operation is the highest. So the perioperative short-term and long-term survival rates in Fontan failure patients are lower compared with the other CHD and the non-CHD heart transplantations. But for Fontan failure patients, the heart transplantation is still the best treatment strategy. We know the preserved ventricular function and heterotaxy is the risk factors for unfavorable transplant outcomes after Fontan procedure. The hypoplastic left heart syndrome has a very low incidence in China, so we have very limited experience in this group. But we know the hypoplastic left heart syndrome is one of the main indications treated by heart transplantation in only years. But nowadays, we know the heart transplantation for these patients is usually performed following the normal procedure. The biventricular patients' indication are similar with the single ventricular patients. Many articles reveal that the survival of biventricular is better than single ventricular transplantation. So When we do the heart transplantation for adult with CHD, we face many technical challenges. The first important is this operation should be carried out at a center with experience not only in the heart transplantation, but also with management of congenital heart disease. So it's a MDT team work. As to the donor heart protection, in our center, we use the Thomas 2 cardiac pressure induction plus a cold HTK solution for myocardial protection. But we believe in future, maybe the normal thermic mechanical perfusion system, like the transmatics system, maybe have more advantages for heart preservation. In most cases, we use the bicaval anastomosis. And if you care about the growth problem, especially for pediatric patients, you may use the PDS suture. When you use a very large donor heart in a infant or in a pediatric patients, maybe you need to delay the sternal closure. Maybe you face the secondary hypertension, reactive cerebral edema, and pulmonary hypertension. But if you use the very small donor heart, maybe you need ECMO support at early stage, and you have to pay attention to left heart drainage. During the heart transplantation, you need to repair the abnormal pulmonary venous return, abnormal vena cava drainage. You need to deal with the abnormal position and the shape of the atria. And then sometimes you need to rebuild the pulmonary artery and repair the coarctation of the aorta. I would like to introduce some data from our center. In Wuhan Union Hospital, from 2008 to 2022, we have performed 56 cases of congenital heart disease, accounting for 5.7% in all the cases, in all the heart transplantation cases. In these CHD patients, 31 is adult cases, account for 55%. So this is the respiratory diagnosis. 12 single ventricular types and 19 biventricular types. The disease distribution similar to the international data, often complicated by complex heterotaxy syndrome. This is the donor information. In China, many donors, we get a donor heart from other province. So about 40% of the donor has a cold ischemia time between 4 to 6 hours. And 42% of patients has a cold ischemia time from 6 to 8 hours. So 12% of the patients, they need ECMO support, and 40% of the patients, they need IBP support. In almost most cases, we use the bicaval anastomosis, and 80% of the patients receive HTK or UW reperfusion technique. So this is the prognosis after CHD heart transplantation. The 5-year survival is 67%. But in our center, we found that the adult CHD heart transplantation survival rates are higher than pediatric. Maybe for the pediatric or infants, they have wait for, it's more difficult for them to wait for a donor heart. And they face many problems such as the donor and the recipient mismatch problem. We have performed 9 cases of fountain failure patients. 4 of them are adult cases. In this case, in these 4 cases, we have performed Chinese first combined heart-liver transplantation for Fong-Tang failure. This patient accepted the GONG procedure, 5 years old, and he finished Fong-Tang procedure in 2004. And after 16 years, the patient suffered heart failure and severe liver dysfunction. So in 2025, he accepted the combined heart and liver transplantation, and he recovered. It's okay. So in Wuhan Hospital, we have performed 3 cases of combined heart liver transplantation. In addition to the case mentioned above, we have 2 cases of combined heart liver transplantation. One is Epstein anomaly, the other is trilogy of Fallot patients. For dextrocardiac heart transplantation, we simplified procedure because when we do the operation, we rotate the donor heart 90-degree clockwise around the left atrium. So when we finish the left atrium anastomosis, the apex of the heart points to the right. So this technique is simple and improve the outcome. When we do the operation, heart transplantation, we need to repair the TAPVC, we need to repair the coarctation, and sometimes we need a conduit to connect it to the right ventricular and pulmonary artery. We need a conduit to connect the left superior vena cava and the right atrium. For patients with MAPCs, we use the one-stop hybrid technique. And before the heart transplantation, we perform the transcatheter embolization of the MAPCs. Then we do the heart transplantation. So this one-stop technique can simplify the procedure and improve the outcome. Thank you.
Thank you very much, Dr. Zhou, for a nice presentation. I'm very, I very much enjoy your talk, and also congratulations on your great success for heart transplantation for adult congenital heart disease in your center. As I mentioned before, that you are the largest heart transplant center in China. Could you introduce us, or do you have data that your center performed what percentage of the congenital heart disease for transplant in China?
In early years, I believe we performed the congenital heart disease cases is more than maybe half of the congenital heart disease cases in China. But in these years, there are more and more children's hospitals. They have the qualities to perform the heart transplantation. So I believe the case of CHD is increasing in China. But in our center, the congenital heart disease transplantation is only 3 to 4 cases 1 year. Yeah. So okay. I believe in future there are more. I believe the children's hospital will perform more congenital heart disease transplantation. Yeah.
So do you think pediatric cardiac surgeon is who is the best person a surgeon to perform the heart transplant for adult congenital heart disease or congenital heart disease? Is pediatric cardiac surgeon or adult cardiac surgeon?
I believe congenital heart surgeons should be performed congenital heart transplantation because it's not a very easy operation, especially I think it's the most difficult cases in heart transplantation. For adult surgeon, they not know where about the abnormals of extracardiac anomalies, including the hypoplastic pulmonary artery, the MAPCs, the TAPVC and the coarctation of the aorta. I believe so. So in our center, all the cases are performed not only by the adult patients. They must ask for congenital heart to finish the operation together. Yeah.
So it's a teamwork in your center, right? Okay.
Yeah,
Thank
it's
you.
a teamwork.
So I wonder if Professor Otto and Professor Kamara, if you have any comment or questions for Dr. Zhou.
Perhaps I can ask one more question. During the transplantation, you mentioned that if there is a discordance between the donor and the recipient's weight, you put on some time to the ECMO. So what's the average time of ECMO that you before you wean? Is it a long period of time, or just happens and you can wean easily?
I think in our experience, this happens in children or infant patients. Sometimes they received a very small donor heart. So when they finish the heart transplantation, maybe we need ECMO to support the heart. For most of the cases, we support for less than 1 week. So the heart will adapt to the hemodynamic, so we can stop the ECMO. So in most of the cases, I think the ECMO support is about 1 week. Yeah.
Oliver, do you have any more?
May I ask a short question? What do you recommend to use for the RVPA conduit with transplant? What type of do you use Contegra? Do you use homograph? Do you use biological valve with Dacron?
Beg your pardon?
If you when you do the transplant and you need a RVPA conduit between the right ventricle and the pulmonary artery, what type of material do you use?
Because in this case, it's the RV, because in some certifications, they do not have the pulmonary trunk. They have a left and right pulmonary. Okay. So in fact, we need a conduit without valve. It's okay, because the donor heart has the pulmonary artery. So we just use ordinary conduit to connect it. It's okay. Yeah. I think which type of conduit is not so important in this situation. Yeah.
Okay. And just another short question: do you experience rather right heart failure, and you need an ECMO for it? And regarding especially to the Fontan patients, because these guys have problems with the lungs most of the time. And what is your experience with the right heart failure of the donor heart?
I think the right heart failure is very important in CHD patients, because many patients in this patient, they have the pulmonary hypertension, and some patients, they have a hypoplastic of pulmonary artery. Even for Fontan failure patients, the PVR is, in fact, is high. Also, the pulmonary pressure is not so high. So in the first case of our Fontan patients, they in hospital death because of the, I think is associated with the right heart failure. And I think so in Fontan failure patients, I think the right heart failure is important. Yeah. So in this case, if the pulmonary hypertension is reversible, in this case, we use the ECMO to support the right heart. Most of the
by the way, do you use VAD and temporary VAD to support or for
yes, I recommend they use the temporary VAD, but maybe they have the habit to use the ECMO. Maybe this patient they also have problem of pulmonary problem or the left ventricle problem. Yeah. So in this case, in this case, we use the ECMO support. Yeah.
Harold, do you have any question?
Perhaps I may ask a final question as a cardiologist. A major problem for us is what's the right time to refer an adult congenital heart patient to the transplant center? Don't say not too late, but what happens with patients who are presented there and are not accepted for transplantation? That is really a big burden, a psychological burden for the patients. Any comment from your side?
Yeah, because in all the 3 cases of combined heart and liver transplantation, they are all CHD patients. I believe this patient, if the patient accept the transplantation 5 or 6 years ago, earlier, maybe they just need a heart transplantation. But for this patient, when we wait too late, the patient suffering severe liver dysfunction. So they have to accept the two organ transplantation. It's very difficult. In fact, it's so difficult to wait for 2 organs for one patient, even in China. So I think UKMN is very important. We cannot perform the operation, perform the transplantation too late. Yeah.
Are you performing neonatal transplantation as well? Neonate period.
Unit?
Yeah. Do you
newborn
perform transplantation for instance, hypoplastic for hypoplastic?
We have performed infant transplantation about 2 months old. Yeah. But we do not have the newborn patient transplantation. Yeah.
Okay, SICHONG, are you still there?
I wonder if I understand your question. You mean the newborn, the newborn heart transplantation, right?
I believe there is a technical problem. And well, I think we should come to an end now. And I thank all speakers and presenters and all chairpersons for this session. And I hope we can have another session next year again. And thank you very much and have a nice day. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.